The issue of sleep is one that I think many of us can relate to, whether we've had head and neck cancer or not, whether we're the caregiver of a head and neck cancer or not. And we sort of talked about how all of these impacts can affect our cognition, our hearing, all of these different things. And sleep is a common trend that can certainly impact our cognitive state. It can impact our willingness to eat. It can impact our hearing and our ability to understand speech and noise, as Dr. Fitzgerald talked about. So we're going to focus for the next little bit of time here on sleep. And it's my pleasure to introduce Dr. Barwick, who is a expert in behavioral sleep medicine, and she's the Associate Division Chief for the Division of Behavioral Sleep Medicine here at Stanford. On a personal note, she personally got me through my own insomnia issue a few years ago from my stress. So I can attest to the efficacy of the treatments that she will talk about today firsthand. So let's start off with just having you introduce yourself and talk a little bit about your perspectives on sleep.
Thank you so much, Heather. Can everyone hear me okay? All right. Yes, I'm really grateful to be here today. I appreciate the invitation. Obviously, I'm a big believer in the importance of sleep, and so I'm always happy to talk about it because there are a lot of misconceptions about how you establish and maintain healthy sleep. Heather introduced me briefly, but I will introduce myself as well. I am Fiona, Dr. Barwick, Clinical Associate Professor in the Sleep Medicine Division within the Department of Psychiatry and Behavioral Sciences, and as Heather mentioned, the Associate Division Chief of Behavioral Sleep Medicine. My areas of expertise are insomnia, which is a big bucket of sleep problems, including problems falling asleep, staying asleep, waking up early, unable to get back to sleep. With head and neck cancer, it does seem to be more common that people have trouble falling asleep, but I don't know about you, I see a lot of folks who have trouble getting back to sleep when you wake up at night. There are a lot of reasons for insomnia. We'll talk about some of them. My other area of expertise is circadian rhythm disorders. So circadian rhythm disorders reflect a misalignment between internal timing of sleep and the external requirements of the environment. So you're not allowed to sleep and wake in the window that works best for your body clock. And the various causes for this. I think what's interesting is there is some evidence showing that in head and neck cancer, there can be alteration of some circadian clock genes. So for both of these disorders, insomnia and circadian dysregulation, they can be common in head and neck cancer. 80% of folks, whether you're in the diagnosis, treatment, or survivorship stage, will experience at least mild sleep problems, and 40% are going to experience more significant sleep problems. That reflects the insomnia piece. There's also a lot of fatigue and daytime sleepiness. Half of people tend to experience problems like this, which further compound insomnia at night and circadian dysregulation. We'll talk a bit more about how sleep gets disrupted with really any form of cancer, but that certainly includes head and neck cancer. And then we'll talk about the treatments for this. The way sleep gets disrupted, I think the important thing to understand with this is how sleep works. Because once you understand how sleep works, you have a much clearer understanding of how and why sleep gets disrupted. There are three systems you want to understand. The first is your stress response. Stress, not surprisingly, disrupts sleep. That is the goal of stress. That's the role of stress. Because the assumption with stress is there is a threat you need to be awake for. Now, evolutionarily speaking, back when the threat at night was attack by a predator or enemy tribe, it made a lot of sense that we should be awake at night because the threat to life was imminent. Or nowadays, if there's a fire at night or a tornado at night, we do need to be awake because, once again, the threat to life is imminent. I think the challenge with cancer is there is a threat, but it's not necessarily coming that night, and yet the stress is there. And stress is antithetical to sleep. If you are stressed, you're going to be awake. And so part of getting better sleep is getting better at managing the stress, which can be incredibly challenging because stress can be very high. But that's one of the first ways that sleep gets disrupted – when you're diagnosed, undergoing treatment, or in survivorship from cancer. The second way it gets disrupted reflects this next system, which is your sleep drive. Sleep drive is a biological drive that works like hunger. With hunger, the longer you go without eating, the hungrier you get. Sleep is similar. The longer you go without sleeping, so the longer you're awake, the hungrier you get for sleep. And the hungrier you get for sleep, by the time you hit bedtime, the faster you're going to fall asleep, the faster you're going to get back to sleep. Now, how do you build your sleep drive? Well, you build your sleep drive by being awake and active during the day, which can be really challenging. If you're experiencing fatigue after chemo or radiation, or you're falling asleep during the day, both of these things are going to lower your sleep drive, and lower sleep drive, less sleep hunger at night means more wakefulness at night. So this is one of the big ways in which sleep drive gets disrupted. People are sleeping more, they're less active during the day because sleep drive builds with activity, especially physical activity during the day, as well as wakefulness. The less active you are, the more time you're spending resting, the weaker your sleep drive will be. So this is another way in which sleep gets disrupted. And the final way is this circadian dysregulation. I mentioned that direct role, this potential alteration of certain clock genes, the circadian genes, but there's an indirect role as well. The important thing to understand about the circadian system is the circadian rhythms are these 24-hour rhythms, so they fluctuate across the 24-hour day, and they regulate a lot of our behavior and physiology. So the big behavioral circadian rhythms are your wake-sleep rhythm, your feeding-fasting rhythm, your activity-inactivity rhythm, and your light-dark rhythm. And what happens with cancer, especially if you are sleepy or tired during the day, all of a sudden you are less active during the day. You might be spending more time indoors, so getting less outdoor light exposure. And then in the evening, you might be more awake at night because your sleep drive has been lower, so there's not as much to carry you through the night. Maybe you pick up your phone or your tablet, so now you're getting light at night. And so the circadian rhythms, rather than being robust and distinct between day and night, weaken. You really ideally want this very clear, strong difference between day and night. So during the day, you want to be awake, you want to be active, you want to be getting light, you want to be eating at appropriate times. And at night, you want to be inactive, in the dark, not eating. And the more that distinction gets blurred, the more irregular your circadian rhythms become. And we do seem to feel best and function best when we have robust circadian rhythms. So these are the three ways in which sleep can get disrupted, and usually with cancer, it's all three. The good news is there is very effective treatment for all of this, and the treatment is not medication-based, which I think is especially helpful because the medications that are often used to either help disrupted sleep or reduce daytime sleepiness are either poorly tolerated or contraindicated with some of the treatments that people are undergoing. So it's really great that the most effective evidence-based treatments for both insomnia and circadian rhythm disorders are behavioral treatments. Now for insomnia, which again is the wakefulness at night, the evidence-based treatment, the gold standard treatment, is cognitive behavioral therapy for insomnia. I am guessing, I wasn't here for the rest of the talks today, but I'm guessing someone earlier has mentioned this in some other context. Is that true or not? No. Oh, okay. Great. Okay, so cognitive behavioral therapy, very simply put, is changing the unhelpful thoughts and unhelpful behaviors that interfere with sleep. Now, you are welcome to be skeptical. I know this sounds trivial, but in fact, all of this is based on that understanding of sleep and circadian biology that I just went through. And in fact, CBTI, based on 40 years of research, is considered the gold standard treatment. It is endorsed as the frontline treatment by every major medical and health organization in the world. So despite your skepticism, the research and my clinical experience and Heather's experience absolutely support the idea that this is very effective. Oh, Dr. Capasso. Perfect timing. No, but I was happy to take the floor. So cognitive behavioral therapy changes the unhelpful behaviors and unhelpful thoughts that interfere with sleep. Why do you want to do this? Well, let's think back to those three systems. Stress. Stress is going to wake you up at night. And what are you going to do when you're awake at night? You're going to worry. You're going to worry about the cancer, no matter what stage you're in. Or you're going to worry about family or finances or maybe the state of the world. And guess what? The more you worry, the longer you're awake. And so, as I mentioned, managing that worry effectively is part of getting better sleep for all of us. And it's especially important when stress is so high. Usually worry, actually not even usually, there is always something inaccurate about worry. It is never completely true, and it is never helpful. And this is especially true at night where there's nothing to distract us. And it's also true because the way the brain shuts down for sleep, the part that goes offline is your frontal lobe, the executive functioning. So your reasoning, your problem solving, your emotion regulation is offline. And the part that gets amplified is your emotional brain. And guess what's going to happen? When you wake up at night, you will be hijacked by your emotional brain, and you will spend 2 or 3 hours worrying about everything. So you want to recognize this tendency, number one, so that you don't necessarily accept the invitation to worry for 3 hours, because there are other things you can do instead. We'll talk about what some of those are in a moment. But that's the first thing to recognize, that your sleepy brain is not the same thing as your wakeful brain, or it's not in the same state as your wakeful brain, and you don't necessarily have to let it take over. There are different ways of reducing stress or anxiety. Now, if the stress or anxiety is focused on sleep, you absolutely want to have an accurate understanding of sleep. There's some very common sleep myths. The first one, everyone should get 8 hours of sleep from 10 to 6. Who has heard something like that? Just raise your hand. Yeah, half the room at least, right? So this is not accurate for everyone. It's not helpful. There's normal variability in both sleep duration and sleep timing. The normal range of time in bed, with the assumption that most of that time you're asleep, is about 6 to 10 hours. So some people just need to be in bed for 6 hours to get the right amount of sleep. Some people need to be in bed for 10. So you want to understand what your sleep need is, because if you don't understand that, you're actually going to do the wrong things. This is where changing the thoughts, so this inaccurate understanding of sleep, you need 8 hours, leads to changes in the unhelpful behaviors that ultimately benefit sleep. So as an example, let's say I'm someone who needs 6.5 hours of sleep. And by the way, when they've done studies looking at sleep in indigenous hunter-gatherer tribes in Africa and South America, adults on average, and these are tribes that have no electricity, no devices, they are out foraging, hunting all day, physically active, getting outdoor light in their huts with a fire at night. On average, adults got 6.5 hours of sleep. That apparently is their sleep need. So if I'm someone who needs 6.5 hours of sleep, but I think I need 8, and I'm spending 9 hours in bed to get the 8 hours I don't need, I've guaranteed myself 2.5 hours awake at night, I now have insomnia. So understanding what normal sleep looks like for adults, how it differs between individuals, figuring out your optimal sleep window, both in terms of where it's placed and how long it is, and then sleeping in that window, which often means spending less time in bed at night. Pretty much everyone I see with insomnia is spending more time in bed than they need to be, certainly more time than they can fill with sleep. That makes their sleep worse, because guess what? When you do that, you're going to worry more, which means you'll be awake longer, and your sleep drive will be lower. Again, if I'm someone who needs 6.5 hours, I'm spending 9 hours in bed, that's 2.5 hours I could be awake doing things and building my sleep drive. So that's an example of changing unhelpful thinking around sleep that leads to a change in an unhelpful behavior. Now, the other thing you want to do is boost your sleep drive. How do you do that? By spending less time in bed at night if you're spending too long in bed, but also by figuring out ways to strategically and safely increase your activity level during the day. This is very challenging because, as you all know, fatigue and pain are so common with cancer, both the treatments and the aftermath. And so you do want to be aware of this. You want to strategically and safely re-engage with activity, but physical activity is one of the best ways to build your sleep drive. So is daylight exposure, especially outdoor light exposure. And just so you know, light through windows, nowhere near the same. It's going to eliminate most of the helpful wavelengths. Even 5 minutes of outdoor light exposure, you'd have to stand in front of a window about 5 hours to get the same amount of light exposure. And light exposure will actually counter daytime sleepiness and daytime fatigue. Even a light therapy box will do that. And if you are less sleepy and less tired during the day, you're going to be able to do a bit more, which means your sleep drive will be higher. Conveniently enough, outdoor light exposure also boosts your serotonin levels. And serotonin is a precursor to melatonin, and melatonin is our sleep-promoting hormone. So all of these things can help with sleep, help reduce the wakefulness at night by boosting your sleep drive. We haven't really talked about what you do if you're awake at night. By the way, it's common to wake up at night. On average, adults wake up 10 to 12 times a night, which I'm sure is a shock to pretty much everyone in the room. What wakes us up is not what keeps us up. What keeps us up is that hijacking by the emotional brain. And so you really want to develop and practice skills that give you alternative choices that make it more likely sleep will return. Things like relaxation, so diaphragmatic breathing, progressive muscle relaxation, body scan. You can develop a mindfulness practice that also keeps you calmer at night, because the way sleep works, your sleep drive is high because you've been awake and active during the day, and you relax. That's how sleep unfolds. So if you're awake at night, rather than stressing out, you're lying there doing your relaxation, maintaining a calm and relaxed state, it is more likely sleep will return. I do want to keep an eye on the time because I want to... I'm almost done.
That's why we pay her extra. I mean, I know her forever and I still keep learning. So like, Fiona, just let me be here, very quiet, and then we're going to talk later.
Okay. All right. The final thing you want to make sure you optimize is your circadian system. Remember, this gets dysregulated. The two things you want to keep in mind: appropriate light-dark exposure. So light-dark exposure is the critical factor in generating circadian rhythms. The two critical times are morning and evening. Those are our most circadian sensitive times. So what do you want to do in the morning? You want to get up at the same time, roughly the same time every day, no more than, I would say, a half-hour difference, at most an hour. When you keep a consistent morning rise time, that is probably one of the keys to keeping your sleep on track, because that morning rise time sets the timing for sleep the coming night. And so if you're waking up or getting out of bed at different times, that is going to mess up your circadian rhythms. Then once you do get out of bed, you want a morning routine that includes light, movement, and food. Because all of these things do what needs to happen in the morning. The three things that need to happen in the morning from a circadian perspective: you need your melatonin to go down and your body temperature and cortisol to go up. Light suppresses melatonin more quickly. And by the way, if you think you should wake up refreshed as an indication you slept well, you are not correct. There is normal morning grogginess, which is known as sleep inertia. It just reflects melatonin leaving your system in the morning. It passes most quickly if you get up. So if you linger in bed, you're just going to prolong the grogginess. If you get up and get light, a bit of movement and food, that will suppress the melatonin more quickly, which will reduce the grogginess. It will increase your body temperature and cortisol more quickly, which will increase your alertness, and you will feel a heck of a lot better when you do that. So that's your morning routine. In the evening, you want, conversely, the dark therapy, the dark exposure. Because what has to happen in the evening is exactly the opposite. Your melatonin has to go up and your cortisol and body temperature have to come down. So what do you want to do in the evening? Well, from a stress perspective, you do want a relaxing wind down routine before bedtime so you can transition to sleep. Because remember, the way sleep works, your sleep drive is high and you relax. But most importantly, you want to be off your screens for two reasons. You probably have heard of blue light. Blue light does tend to suppress and delay melatonin because it's an alerting cue. And if you're suppressing and delaying melatonin, it's harder for you to fall asleep and probably harder to get back to sleep. But more importantly, the content on your screens is going to keep your cortisol, your stress hormone, high, and it's going to keep your body temperature high. So when you're on your screens, literally nothing that needs to happen before bedtime is happening. Because I can guarantee you, when you're on your screens, you're either looking at Dr. Google to find out all the information you can, or you're looking at social media to see how everyone is living their best life, or you're just looking at the news or politics, and none of this is relaxing. So from a circadian perspective, you really want to reinforce those morning and evening routines, because that is what is going to keep your sleep on track. The final thing I want to mention, melatonin, lots of controversy about melatonin. Happy to answer questions about that. But It does look, at least from very recent studies, still limited in number, melatonin is an interesting hormone. It is a sleep-promoting hormone, but it's also anti-inflammatory, antioxidant, anti-apoptotic, apoptosis is cell death, and anti-tumor. And so they're starting to use it in adjuvant therapy, in chemotherapy, and radiation, and the outcomes do seem to be a little better, which I think is interesting. I'm going to just wrap up by saying I see people who have cancer at different stages all the time for help with sleep. And when they do these strategies, when they put these strategies in place, they do see improvement in their sleep. Now, often they have to let go of some fantasies, like they're going to sleep the way they did when they were 10 years old, because sleep changes with age for all of us. Usually we get less total sleep time and we spend a bit more time awake, but you can absolutely improve your sleep when you leverage essentially your evolutionary biology, because Mother Nature has spent millennia crafting our response to day and night to our activities. And if we leverage that, it is a much more powerful way of improving sleep. All right, I'm going to pass it over to Dr. Capasso.
Let me introduce you real quick so everybody knows who you are. So this is Dr. Robson Capasso. He's a professor in the Department of Otolaryngology, head and neck surgery here at Stanford, and he also is the director of our sleep surgery division. So he comes to sleep from a different perspective, a complementary perspective, and look forward to hearing your thoughts about sleep in the head and neck population from your perspective.
Thank you. Thank you so much, Heather. And sorry for the delay. Everybody, I swear I didn't write the right address. So very tough to follow that, and that's why I invited Fiona, because I like myself to hear her all the time. And I'm going to do like one point that you pointed out, so that I love the summary that these days, how many of you saw some advertisements about this new, put your name here, pillow, mattress, supplement, app, wearable, whatever, that is going to improve your sleep? And Fiona always keeps telling me, a lot of times we have this illusion that we want a passive solution for something that requires an active stance, where you need to improve all those habits that she just told us. And it's absolutely true. We see this over and over again. So I think having this idea that we do need to have a sleep routine with good habits, and I keep repeating, I stole the line. I tell that to all my patients now. So that's actually incredible, if anything, and I use that myself. And I try to pass that to my teenager kids. That doesn't work. But I think that this is actually quite important for all of us on this room. Is kind of having this idea that sleep, it is very important to have a quite work actively in developing a healthy routine and habits. And another thing you usually say that I love it is, again, don't worry too much about your what time you go to bed, but what you have control of is the time you wake up and the routine you have in the morning. So it's kind of the reverse. People start thinking a lot about, I'm going to take a shower this time, I'm going to buy my new pajama, and I'm going to take my chamomile tea, and they overthink bedtime, while the main time to think about is the wake up time, like waking up at regular time, having the routine as you mentioned. So I think that is a fantastic thing that I steal from you, and I tell to all my patients as well. So besides the behavioral component of sleep, I just want to bring an awareness, because for our population, head and neck in general, there is this other animal called sleep apnea. So two conditions here we want to talk about. One is insomnia and the sleep-related habits. The other one would be sleep apnea. So whoever designed this didn't think very well about this area over here. So the nose, around the nose, we have bone. It's not going to collapse. Here, the larynx, we have cartilage, and so that doesn't collapse either. But then in between here, nothing hangs this thing open at night. So once we are on our 20s, 30s, nature figures out most of the time a way to keep this open, unless we have an anatomic issue. We have a big tonsil or a very recessed jaws. But as time goes, this tends to become more collapsible, as with any tissue in our body. And if you do have some conditions, in particular, if you are obese or overweight, this tends to get worse. And second, as time goes, it tends to get a lot worse once we sleep in our backs. So it's quite remarkable how weight loss and side sleeping can improve sleep apnea in most people. Actually, let me just step back. Any of you here ever heard about this term called sleep apnea? or everyone has an idea? So great. As I mentioned to you, we all kind of narrow somewhat the throat at night when we fall asleep, but some people narrow it too much. So you have this very interrupted sleep with drops in oxygen at night. And then the question is, so what? What is this important? Roughly speaking, for 3 reasons. One would be the socially unacceptable snoring. There is a roommate or a partner complaining about your snoring, and that's a good reason, or not a good reason. That's a common reason why people actually can't.
30% of people whose bed partners snore have insomnia.
There you go. So that is one reason for that. And that is actually quite interesting. It is the funniest thing. Sometimes you have these couples, they're like on their late 20s and they just got together, and you're like, does she or he snore? Oh no, just quite a little noise. Yeah, too bad. And then there is the first kid, and does she or he snore? Oh my God, take this person away from my room. It's like the funniest thing. So you see this phenomenon happening as time goes as well. So it becomes, so objective assessment snoring is something I usually try to do with some apps. And we need to target both because the main stakeholder many times is the partner. The second reason is sleep tests. Literally, almost every male has a positive sleep test. According to what we call a positive sleep test, 80% of males are going to have this surrogate endpoint called the apnea-hypopnea index above 5. So we should not just have a knee-jerk reaction to a positive sleep test. We need to check in particular if the patient has significant drops in oxygen. So there is every time more the concerns regards how many times per hour the oxygen drops and how low the oxygen goes and for how long the oxygen stays, because that has a more straightforward correlation with cardiovascular events and other health-related outcomes. So don't having a panic attack with a positive sleep test, but looking okay. If you do have frequent drops in oxygen, then we need to do something about it. It's a must-treat kind of sleep apnea. And then the third component would be daytime symptoms. So in particular, sleepiness. I love people that are falling asleep all the time, and that is the complaint. I really don't like fatigue. Fatigue is this level of low energy. I'm feeling tired. That is very multifactorial, and that sometimes is not a very straightforward correlation with sleep apnea. So sometimes by treating sleep apnea, fatigue gets better, but a lot of times it doesn't. So that is another thing that is important to understand. So snoring, daytime symptoms, and the hypoxemic burden, the drops in oxygen frequently. So that's when we would think about. Does any of you ever heard about CPAP? It's a machine that throws air with pressure in your airway. It's basically a glorified air compressor. It is the machine per se. People asking, how about the machine? Is that important? Well, as long as it's not too loud, it's okay. Of course, I'm oversimplifying. There are many more nuances into this, but the important part is the mask. Is figuring out a mask that people feel comfortable with is important. So there are masks that go inside the nose, around the nose and the mouth, the whole face, the whole head, just the mouth. So there are literally every sort of mask you can think of. It is just trying and figuring out one that feels somewhat comfortable. The way I like to joke about it is, if you use CPAP, don't care. Drink everything. Take opioids. Go for your benzos. Gain weight. Don't care.
I strongly disagree.
Exactly. But that is the joke. Then she got mad at me. But if you can't use CPAP, then I need you out of all of that, because this actually messes up with the breathing drive, with the muscle tone. It makes our life very hard if we need to do anything non-CPAP. So weight loss, discontinue any medications or substances that cause muscle relaxation or decrease the breathing drive, like benzos or opioids. It's very important for us. And then the last thing is side sleeping. It is very important as well. The majority of adults have a much stronger problem breathing at night when they sleep on their backs when compared to side sleeping. So that's going to be quite important as well. So that's a very high-level introduction for sleep apnea. We can go into a lot of details, but I always feel that it's very important to have your questions, that we can target them a little bit more.
Sounds.
Thank you.
So you mentioned CPAP. Could you talk just a briefly bit about BiPAPs and some of the challenges with CPAP versus BiPAP and challenges with BiPAP in itself?
Again, oversimplifying a little bit. PAP, positive airway pressure. Some patients require higher levels of PAP once it gets to be 12, 13, 14 centimeters of water pressure. In some patients, tolerability tends to get a little harder. So some patients then become a bit more tolerant when you give them a differential of pressure, let's say 16/12, so it creates a waveform. So it becomes a little easier to breathe. So tolerability is one indication. The other one is some patients, in addition of having the throat blocking, they may have a bit of hypoventilation, meaning the lungs are not expanding enough. So you breathe the bilevel PAP, it breathes a bit to this particular patient. So not only relieves the obstruction, but makes that differential, allows for inhale, exhale. So it does cause some improvement on ventilation in the lungs as well, beyond relieving obstruction. So those would be the two big ones. Then we're going to go into a lot of other details, but that would be the main proposition of bilevel in when CPAP's not a good choice.
It just seems really weird to me that CPAP there is a CPAP and it's not all BiPAP in terms of you're breathing in, breathing out, breathing in, breathing out. It'd be two different pressures regardless.
So CPAP even have an expiratory pressure relief setting that you can program on that kind of almost look like a bilevel, but you do have a little bit, the pressure relief is not at the level that you usually have with BiPAP. It is just a 1 or 2 centimeters of water pressure.
And let me add a little bit from personal experience. We are lucky enough at the Sleep Medicine Center to have wonderful sleep technologists. They do overnight sleep studies, and one of them offered to give myself, my team, my fellows, an introduction to all of this. So we got to spend 4 hours with her as we tried different masks at different pressures. And I was shocked to find that I preferred the CPAP, the continuous pressure. Now, the centimeters of water pressure was lower. It didn't reach the level that Robson talked about, the 12. But with the bilevel, what I found is the increase in pressure was much more noticeable when, after the expiration. And so that was my personal experience. I'm not saying it would be everyone's, but I was surprised.
And especially when we get to our 60s, 70s, then what happens as well is the breathing phenomena we have at night, sometimes it may start as an obstructive event, but it progresses a bit with central event or vice versa. So it becomes what we call a mixed event. So on that case as well, the BiPAP kind of helps on some of those patients. So there's a lot of details we can get in there.
You're welcome. Rod, you raised your hand.
My question is about using eye masks. I use them, and it's quite effective for my sleep. But I can wake up at, say, 8 o'clock in the morning with an alarm. But I know that the light is coming out already at 6:30 and 7:30. Is it okay that I keep my eyes totally dark during that time, and then when I take the mask off at 8 a.m., and then I was like, it's so bright out.
No, that's perfectly fine, as long as you're sleeping in the right sleep window. And remember, sleep differs between individuals, not only in terms of how long they need to sleep, but when they need to sleep. So someone I saw just yesterday, her bedtime is her sleep window is 1 to 8. So she should be sleeping in that window. I don't know that she uses an eye mask, but we are very sensitive to light cues. We can sense the gray light of dawn through our closed eyelids. There's individual differences in that as well. So, and there is, I don't know if you're an evening type or not, but there is some evidence that people who are more evening chronotypes, so they have a later sleep window, may be more sensitive to light. So eye mask, totally support it.
And also, is there a preferred sleeping position?
No, there's not, apart from the sleep apnea sleeping position, which would be side sleeping. But no, most people do seem to sleep on their side. I would also say what research shows is people have no idea what position they sleep in. So maybe 10% of people report their sleeping position accurately, but most people are all over the place, even though they think they're always sleeping on their back. So there's no preferred sleeping position.
Thank you.
I have two separate questions for each of you. So I was diagnosed with sleep apnea, but given my cancer history and my saliva glands damage, I was prescribed a CPAP. There were some troubles, maybe because my face is smaller than normal patient with fitting. And then there was because I was moving. So I kind of stopped using the machine for a while. I've been thinking about maybe I should start using it again. So for a patient like me who once prescribed CPAP but haven't used it, the machine's still there, how do I, do I need to go to a revisit with a sleep clinic to figure out if I can continue that, or should I just try it myself?
Tell me your name again.
So Amy.
Amy. So I'm not being recorded, and this is not a medical consultation, but you are the type of patient that we are like, okay, what do I do here in the clinic? And we can go forever on that. There are so many paths that we can recommend you to go almost. But
what I would say is I'm not going to sugarcoat this. I do think the whole setup for diagnosing and treating sleep apnea, helping people get their CPAP, is riddled with obstacles and challenges. And so we have a PAP adjustment group to help people adjust to PAP. And because we see so many people who either don't want to use it or have tried it for a few times and given up, or have tried it for a long time and have gradually let it lapse. And there are very good reasons why that happens. At the same time, it can be important, as Robson said, to treat this because there can be the hypoxemia, the daytime sleepiness that can disrupt sleep for multiple reasons. So what we are learning is probably the best path, or the path with the greatest likelihood of success. You should get another sleep study. Sleep apnea often worsens with age. Then the next thing you want to do, if you're at least fortunate enough to be seen here at Stanford, is get a mask fit, because the sleep technologists at the center have literally fit thousands of patients. They are unbelievably good. They can literally look at you and say, let's do these 3 masks. So you get a mask fit, and you do that before you go to get your CPAP, because the people at the companies that provide the CPAPs do not have anywhere near the experience that our sleep technologists do, and they'll just give you the first thing they want to get off the shelf. And if it doesn't work, you're left trying to figure that out, which is virtually impossible. So by the time you get your device, you will know what mask you want, you will know the device you want, and then when you start using it, you may want to come back for another mask fit, or you can certainly join our PAP adjustment group, but that would be the path that would give you the greatest likelihood of success.
In 100%. One aspect that I like to bring, and I think it is a big unmet need, it is especially for ladies on their 50s, 60s, and later, that is a tricky phenomena, because sometimes there is a deterioration on sleep quality, and there is a 60% chance that you will test positive for sleep apnea, because that is literally the number of females that test positive for sleep apnea is around 60% on that age frame. The question is, do you feel better with CPAP use? Do you feel any benefit in your sleep with CPAP use? And if your main complaint would be fatigue and poor quality sleep, fragmented sleep, something, and you do perceive benefit with CPAP, then I would recommend treat it. What we see sometimes is this quest for like, okay, I can't use CPAP, what else? What else? And then to which length do you go? So I would say some patients treating sleep apnea becomes more of a quality of life, but I would maybe think, okay, I would not think about a very aggressive surgery in some patients with mild sleep apnea and complaints of fatigue or fragmented sleep. I become more aggressive with someone with severe sleep apnea, a lot of hypoxemia, and then I will become a lot more heavy-handed. So having that in mind, it's quite important as well.
My other question, you guys are going to laugh at this. I know Apple has that blue light filter, the yellow, whatever, blue, kind of yellow it out. And there's also the other one, I think the flax, that kind of yellow out your screen. Is that working or not, the filtering up blue light?
Probably what has the greater negative effect on sleep is the contents.
Okay.
So you could almost ignore the light. I mean, the flux or the night shift setting, to block, in order to effectively block blue light, you have to block 99% or more of the light. So everything has to look distinctly orange. And so if you look at those, the flux or the night shift, it looks vaguely yellow. But even if you block the light effectively, it is not going to block the content. That's the main problem.
Okay. Thank you.
I use that too. That.
Thanks very much. This is very informative. I use a BiPAP. Does sleep need change over time as one ages? Because there's the myth that says, well, as you get older, you need less sleep. I don't know if that's not true.
It's true that we get less sleep over time. We get less deep sleep especially, but that's partly because deep sleep is associated with growth. So the kids and the teenagers are getting the deep sleep they need. We get less deep sleep as we age. We get less total sleep as we age. And so what you want to do is you want to adapt to those changes in healthy ways, rather than extending time in bed to try to get the sleep you used to. It's just going to increase wakefulness, weaken sleep drive, and ultimately worsen sleep. You want to figure out the right sleep window depending on who you are and where you are in your lifespan.
And that's just a process of trial and error, I guess, as I get older. To see.
Yeah, the way to do it would be to figure out, I mean, you could certainly I would let yourself sleep as long as you can. See if you can figure out the right timing as well. You don't want to go to bed until you're sleepy. So oftentimes I see night owls who are getting into bed at 10 p.m., lying awake for 3-4 hours. That is not a recipe for good sleep. So you got to figure out the right timing. And then once you do, go to bed when you're sleepy, allow yourself to sleep as long as you can. Do that for 2 weeks, see what the average is. And there may be some times you're sleeping a little longer, some a little shorter. Sort of take the middle ground. Keep that sleep window, add half an hour, and then keep that sleep window for a couple of weeks, see what happens. It's probably, it's the sleep window you pick will probably be a little shorter than your longest one, and it probably will be a little shorter than 8 hours. That's usually what I find.
And just one more thing to add. Anyone has any idea what is the most commonly used sleep aid? Alcohol. Everybody drinks that glass of wine at bedtime, and that kind of tends to mess up sleep as well. So that is another thing that is important. That glass of wine at night too close to bedtime, it may cause you to have a more fragmented sleep, worse snoring, worse breathing, and that usually tends to, with the fact that people are getting older, make the significant decrement of sleep quality. So just remembering that one factor, that is the use of alcohol close to bedtime, not a great idea, Fiona.
Yeah. Actually, the first thing I tell people is the fastest way to get improvement in sleep is take a 4-week alcohol holiday, especially if you're using it regularly. You need a couple weeks for your brain to recalibrate if it's gotten used to having the glass of wine, couple glasses of wine at night. And then you need another couple of weeks to experience sleep without all of this, and then bring the alcohol back. And that is when you will see the effect. Because what's happening is, as alcohol is metabolized, first alcohol spikes. It increases GABA, which is a inhibitory neurotransmitter. So it helps you relax, which is why it is the most widely used sleep aid. Remember how sleep works. Your sleep drive is high and you relax. And so that glass of wine, that cocktail is helping you relax after a busy and stressful day. So you may fall asleep more quickly to start with, but unfortunately, the body always craves homeostasis. And so what happens halfway through the night as the alcohol is metabolized, GABA drops to a level that was lower than when you started your night. And what's released instead to restabilize is glutamate, which is an excitatory neurotransmitter, an activating neurotransmitter. So now you got that circulating through your system halfway through the night. In addition, alcohol spikes blood sugar, and the hormone that's released to restabilize it is cortisol, your stress hormone. So now you got glutamate and cortisol in your system halfway through the night, which is why you're wide awake or tossing and turning and getting fragmented, poor quality sleep. Not to mention, it, as Robson said, it does worsen sleep apnea.
You don't need to do a slow answer. Quick answer would be great. Is just in terms of, as an example, Somnodent is what? Somnodent oral appliance versus CPAP. Any quick thoughts on that?
So, for some of the patients with the right anatomy, so that's actually opens up there. The way I joke about it's a third of the patients I prescribe CPAP, they love it, their new best friend, oh my God, they just adore it. A third of the patients are like, and a third of the patients prefer to see the devil. in front of them other than use CPAP. And that's why I have a job. I do surgery in people that can't use CPAP. So one of the alternatives would be oral appliances. So again, the way to think it is all those behavioral components are important: side sleeping, weight loss, avoiding everything, plus some. So oral appliance is one option. There are some over-the-counter ones, and I usually suggest the patients to actually, give it a try. The main reason for that is financial. If you go to a dentist in California, the cheapest one is going to be $1,500 for oral appliance. So buy the cheaper one, $50 online. Just see if you can sleep with something inside your mouth. That is the first step and the usefulness sometimes for this. If you can, then I would invest into something that is a bit more. So usually the patients would be thinner patients with teeth. And when they use the device, they will feel some degree of pain on this joint called TMJ. And they may feel some facial pain as long as they get used to it. And this is not something that is severe and prohibitive and patients cannot use it. Then great. So first step would be tolerability, see if they can use it. And then if they can, then we will assess compliance. So usually our patients who are thinner, sleep apnea is not that severe, the teeth are in correct position or a bit of an overjet, overbite. So the jaw is a bit on the smaller side. You can pull without big tonsils. So those would be in patients that can breathe through the nose. So those are usually the ideal patients for mandibular advancement devices in general, the oral appliances.
Thank you both so much. This was really a wonderful session.